Good morning, everybody. On today's session, we have my mentor, Dr. Maulin Shah, presenting a session. So a little bit about him. So Dr. Maulin Shah accomplished his basic pediatric orthopedic training from the renowned Dr. Johari sir, and then went on to gain more training from Dr. Ponsetti at University of Iowa, USA. He further had the opportunity to get advanced pediatric orthopedic training at the world-renowned Hospital for Sick Children, Toronto, Canada. Then he set up the center here, which is OrthoKids Clinic, where he teaches fellows in and out every year and trains them for the future of pediatric orthopedics. So it is my honor to invite you for this talk.
Thank you,
Kindly
Preksha.
share your slides.
Yeah. Request. Rishi, can allow to share? Yeah.
Yes, sir.
Yeah, thank you. So Preksha, can you see the screen now?
Yes, sir.
Okay, and I'm audible, right?
Yes, sir.
Perfect. So good morning, everyone, and we're going to talk today about radial neck fracture management in children and a bit of emphasis on OrthoKids technique of close reduction. So when this 7 years old girl who has completely toppled off radial neck fracture with radial head is completely disrupted, or something like this where it is front toppled, and if the different options are given to us like close reduction, intrafocal pinning, pinning assisted retrograde tense, like Metazu technique or open reduction. So I'm sure most of you would think that this injury would require intrafocal pinning, and some of you would be interested in doing intrafocal pin assisted Metazu technique. And we all know that open reduction is pretty detrimental because of its possible adverse events like stiffness and avascular necrosis of radial head. And you all are right in this, because the radial neck fracture has been classified based on Jude classification. And based on it, type 1 and type 2, when the angulation is less than 30 degrees, it can be treated conservatively. But when this angulation goes beyond 30 to 60 degrees, this will not end up into natural remodeling, and one needs to adapt close reduction techniques. But the issue arises when it is severely displaced, or Jude type 4, and the literature says that you need to do either percutaneous wire joystick assisted reduction, or in very severe cases, you may end up doing open reduction. So many close reduction techniques has been described in literature, if you see, since 1934, starting from Peterson maneuver and so on. But all these papers, if you read in details, they are described for Jude 2 and 3. And they mention that none of these techniques uniformly achieved complete anatomic reduction in severely displaced radial neck fractures, that is type 4A and 4B. And what is OrthoKids technique? So we have devised a technique to reduce this severely displaced radial neck fractures, that is Jude type 4s, and to avoid an instrumentation or surgery in these cases. So what is this technique? Let me show you an animation at a glance. So the first step is to move the forearm in a position under image intensifier so that you can see the radial head as a rectangular piece, and this is the profile of radial head, or it's a pre-injury position of the forearm. And once you see this, the assistant gives a varus force from the elbow, and surgeon gives a longitudinal traction to disimpact the fragment. And then with your thumb, you push the radial head and convert it from type 4 to type 3. And once it is done, the final and important step is to do a simultaneous flexion pronation maneuver, which reduces the radial head completely and anatomically. So this is, and then you apply plaster in that pronation position. This is stable. You don't need any instrumentation. I'll go through it again. So the first step is to rotate the forearm under image intensifier and see the radial head as a rectangular piece of bone, which is the position in which injury has happened, and further maneuvers should be done in that position. Give varus force to open up the lateral recess, give longitudinal traction so that once you push on the radial head very precisely, it will move in and it will be converted to type 3. And then from this position, you need to do a final simultaneous flexion and pronation maneuver, which will reduce the radial head anatomically. And you can check the stability with the forearm pronated in both flexion and extension in AP and lateral view. And if it is stable, you may go ahead with just a plaster and you don't need to fix it. So what is the biomechanical basis of this technique? So we all know that annular ligament, radial collateral ligament, and the ulnar collateral ligament, which controls the radial head, they remains relaxed when the forearm is supinated. The moment you flex the elbow, this obliterates the posterior capsule and it places the posteriorly displaced radial head in position. And when you pronate the forearm, all these ligaments become tight and it pushes the radial head in its position and it allows it to remain stabilized. Those who have adopted this technique, you will see that once you reduce the radial head completely and then you supinate, you will see there is translation of radial head. So the key point is not only to use pronation maneuver for reduction, you also have to immobilize in pronation, and that's how this will be maintained. So let me show you on a young patient of 6 years old that how practically we do it. And the patient is positioned supine at the edge of operation table, and there is a radiolucent arm board, as you can see, and the image intensifier will come in from one side. And as I mentioned earlier, the first step is to rotate the forearm in different positions, and usually it is a little bit of pronation, 30 degrees pronation from full supination. There usually you see the radial head completely. So you can see in this X-ray, radial head is not seen well, but the moment you rotate it, and then you will see is rectangle. So this is the profile view, and in this position, you have to do your further maneuvers. So the first step is the counter traction is given by your assistant, and then you give a longitudinal traction. This impacts the fracture, and once you do that, the varus force is given by your assistant from the medial side and elbow. And once they give varus force, you turn your forearm medially, and this will open up the lateral recess. And then the most important step comes is to locate the radial head and put your thumb precisely on the radial head. In very chubby children, you might take help of image intensive where the radial head is actually located on the lateral view. And then you give simultaneous sustained pressure over radial head that will convert a type 4 to type 3 neck fracture. Many times you might have to do a couple of 2 or 3 attempts, and you will see the radial head goes there. And finally, in that, with sustained pressure, you do a simultaneous flexion pronation maneuver, and radial head will be reduced completely anatomically, which you can confirm. And now, before you complete your plaster, check the stability of reduction in that degree of pronation with the full range of flexion extension in both AP and lateral view. And in that position where the radial head does not translate, you choose and apply plaster, which is usually in a pronation a little bit more than mid-prone, and you apply plaster. You don't need to do any instrumentation or nailing or K-wiring. This will remain stable. So this is how you apply this technique, and finally you finish your plaster. And we keep this plaster on for 3 to 4 weeks, depending on the age of patient. If you see the radiologic correlation, again, neck radius fracture, after traction, varus, and thumb pressure, it has turned into type 3. And after final pronation flexion maneuver, it got completely reduced. And this is 1 year follow-up and with full range of motion. So many of our colleagues were concerned about loss of supination, but all our patients at 1 year follow-up, they have full range of supination. Let me show you one more example where it is type 4B and completely toppled off radial head. Again, we could successfully employ this technique and could achieve 100% anatomic reduction, and it was treated without any instrumentation. One more example, which is front toppled this, you can see the severity of fracture because the concavity of radial head is seen from the volar side or front side. And this was a child of a radiologist, so he brought these images. We usually don't do CT scans in these patients, but the same thing, you have to locate the radial head, which is anterolateral, and apply the same maneuver, and we could reduce it fully. And then we check the stability under image intensifier in both the AP and lateral view. It was stable, and so a patient was immobilized in plaster. And for a month, this was an, I think, 11-year-old girl. And then this is 1 year follow-up where she's showing full range of elbow flexion, extension, and forearm rotation. So one more scenario we see at times is in very young children where radial head is only partially visible. In this cases, one should add arthrogram, and after arthrogram, you repeat the same procedure. Again, looking at the radial head in profile and then performing the sequence of maneuvers, and you can reduce them completely. So this technique has been successfully used in most severely displaced fractures, and where this technique may not work, So in our initial series, all the patients were less than 1 week old injuries, and one patient who was presented at 9-10 days, we could not reduce. And so we place this term that if it is more than 7 days old, the bone might have already started gluing and this technique may not work. Another condition where the radial neck is associated with elbow dislocation or Jeffrey type injuries, their ligamentotexis cannot be applied because ligaments are disrupted. There, this technique may not work. So let me show you an example. This 10 years old girl was referred to me, and in the beginning, it looked like a very stable, isolated injury. But the moment I tried to extend the elbow to look the radial head in profile, the elbow was dislocated. And you can see the moment we extended, it got dislocated. So in this condition, the technique did not work, and we resorted to open reduction and then placed a K-wire through non-articular part of cartilage. So after our publication, which was done in Indian Journal of Orthopaedics in 2020 and later in JBJS, lots of colleagues and my fellows have applied this technique, and we all have kind of extended the indication of radial neck fracture reduction technique in different situations. And let me show you a couple of few examples of that. So this is a case of Dr. Akash Makaria, one of our fellows. And this child had bilateral radial neck fractures. And you can see on right side, it is very simple Jude type 2 injury, which is amenable to close reduction. But on left side, it was associated with dislocation and as well as ulnar collateral avulsion. So, based on our principal publication, we would consider surgical intervention if we fail to achieve close reduction, but this fracture could be reduced with the OrthoKids technique, as you can see. And this is 1 year follow-up of the side where the ulnar collateral ligament was avulsed, and that girl successfully had full range of motion without any instability, both flexion extension as well as pronosupination. So we could avoid surgery and instrumentation in this girl. Another example of extended indication is in Monteggia variant. You can see here there's a proximal ulnar fracture with type 4 radial neck fracture. And when we see this image, initially we think that we need to fix both the pillars of elbow, like we need to fix the ulna as well as the radius. But you can see the CT scan which the family got from a previous surgeon, and you can see completely radial head is lying on the side of the metaphysis of the radius, but we could successfully apply OrthoKids technique, and this got completely reduced, and we applied plaster in mid-prone, and this is a 1 month follow-up, and this child is recovering his range of motion. So this is, in this position, you have to apply plaster. Coming to this injury, like now this is Jeffrey type of injury. You can see the radial head is lying on the dorsal side of the capitulum, and this we see as an iatrogenic injury many a times, where the elbow is dislocated. In an attempt to do a close reduction, the radial neck get fractured. So again, the recommendation is to do either a try close reduction or do an open reduction and fix the radial head. What we could do is there's an X-ray and there's an image intensifier image. So if we read Jeffrey's original description, what we did is we extended the elbow. We tried to kind of re-subluxate the elbow by pushing the distal humerus anteriorly and the forearm posteriorly, which gave us space for reduction of the radial head. And then we used a blunt instrument to push the radial head in its position, and we could reduce it back to its position, as you can see this. And then we did the pronation and flexion, and again we checked in full range of motion, and this was completely stable at that position, and we could continue with the plaster, and we avoided any open surgery in this case. So the key point here was, once you reduce the radial head anatomically, if you keep the forearm in pronation a little bit more than mid-prone, the ligaments will hold the radial head in position, and after 3 to 4 weeks of immobilization, you start range of motion, and as it is anatomically reduced, there will not be any restriction of motion. Coming to a last example, in initial series, we said after 7 days, you cannot reduce it by our technique. But this is a 9 days old presentation of a young child. And as expected, after doing an arthrogram, the radial head was not moving at all. And so what we tried to, we did intrafocal wire-based osteoclysis. So with the wire, we did the osteoclysis, and then we removed the wire. Once the radial head became mobile, we again employed the same technique. And this is 1 year follow-up of that girl, and we didn't require any pinning or metizu, and she gained full range of motion at 1 year follow-up, full pronosupination and flexion extension. So the take-home message is isolated, severely displaced radial neck fractures, that is Jude type 4, without associated elbow dislocations can be treated by OrthoKids technique without any instrumentation, while unstable or neglected cases would need some instrumentation to make the radial head stable. But with this application, with timely presented radial neck, interfocal or Matthew is a history in our center. It is very seldom required. So thank you very much for your attention. I will be happy to answer any questions you have.
Thank you so much, sir. Is there any questions?
So Preksha, is there any question chat box?
There are no questions in the chat box, sir.
Hello.
Hello.
Am I audible, Preksha?
Yes, sir.
Hi, Maulin.
Oh,
Mandar
sorry.
here.
Yeah. Tell me.
Yeah, in the case where you did an arthrogram, you
Hmm.
did it by the routine method from lateral to medial, putting the needle from lateral to medial.
I think I did from posterior approach, going between the ulna and the radial head. So
Yeah, because
yeah,
there is extravasation of the die on the medial side also. That's why I asked.
yeah. This was done from posterior approach.
Yeah. Okay,
So that
okay.
probably, and there the extravasation shows that there is a breach into
Medial
the
collateral. Yeah,
exactly.
the capsule is down on that side also.
Yeah.
Instability.
Yeah, but still we could
Yeah.
reduce it well. And sometimes, when you're once you inject into joint and you withdraw your needle, there might be some
Yeah.
dye extravasation.
Yeah. Okay. Thank you.
So, like if we let me stop sharing here. So
Yeah.
main thing is if any question from anyone?
There are no questions, sir.
Yeah. So main advice or thing which I would suggest is you need to attempt multiple times. At times, at first attempt you see only partial reduction. So some people would ask how many times we can attempt reduction. So I tend to suggest that you try 2-3 times, and every time you will see you are pushing more and more. The radial head is coming up more and more. So have faith in this technique, and once you achieve complete reduction, you will be zealed, and then you will be excited to use this technique the next time as well. Right on. So if you have any question later on, then let us know, and we'll be happy to answer. And Dr. Kunal will post both these articles in our group. How many times we should try? Yeah, you see, there is no harm in trying 3-4 times initially. There are certain cases, especially when the child is extremely uh, there are a lot of fat content, extremely chubby, and in there you try a few times and radial head is not moving, then think that your pressure is not at the right place. Usually the radial head is a bit more anterior than we think. In those cases, you put your thumb and see in the lateral position, but where is your thumb? Is that should be on exactly on radial head, and this needs actually two assistants. One would give counter traction and other would give counter varus force. So have adequate assistance, and you try 2-3 times, and then I'm sure that every time it would improve the position. Okay. So again, thank you very much for your time, and I'll be happy to answer further questions if you have on our WhatsApp group. Have a good day. Thank you.
Thank you
Thanks,
so much,
Preksha.
sir.
Yeah.
Thank you, sir.